Hello, good evening, and welcome to today's discussion. And I'll be discussing HIV-associated nephropathy. Okay, so this is a very important topic. Nephropathy in HIV-infected patients. Okay, this is my outline. So, um, this is my outline: epidemiology of kidney diseases in HIV infection, uh, renal disorders in patients with HIV-associated glomerular diseases, HIVAN pathophysiology, mechanism of renal injury, presentation, renal complications of HIV medications, tenofovir, associated nephrotoxicity, and then summary. We're just going to be very fast, extremely fast with this presentation. This is a very simple and straightforward topic. Okay. Uh, the epidemiological importance of this topic cannot even be underestimated. Okay, see, up to 30% of HIV patients in the US have CKD or proteinuria. You know what that means, right? So, HIVAN is quite a disease of epidemiological importance. So you have fourth leading cause of death among patients with HIV. Okay, so kidney disease is the fourth leading cause of death amongst patients with HIV. Burden of kidney disease among HIV patients, like we know, is not very clear in the sub-Saharan Africa because of data gathering is quite on the poor side. So the estimates of the prevalence can range from 50 to 50%, 5 to 50% in HIV patients. So these are some of the epidemiology that we have in Nigeria. It ranges from as low as 15.8% to as high as 53.3% in Benin. You know, these are quite some challenges. Now, let's look at all the possible renal disorders that can occur in an HIV patient, okay, or a patient with HIV infection. Once a patient is infected with HIV, these are the possibilities that what they can suffer, how they can get CKD or renal disorder. So there's HIV-associated nephropathy, which is the HIVAN we're talking about. Now, the possible causes are some of these primary and secondary renal disorders. So the one that is most importantly associated with HIV-associated nephropathy, especially in Black Americans, Blacks, Africans, we are talking about focal segmental glomerulosclerosis, also known as FSGS. This is the most important disease when it comes to HIV, HIVAN, right? So, especially the collapsing, this FSGS has two types. It has the collapsing and the non-collapsing type. So, the non-collapsing type is particularly important in HIVAN. There's minimal change disease, there's membranous MPGN, there's DPGN, okay, hemolytic uremic syndrome, amyloid. Then unrelated diseases in HIV-infected patients, we have heroin-associated nephropathy, because some HIV patients, maybe it's a heroin IV drug user, IVDU, okay? Maybe that's the source of the HIV infection in the first place. Then obstructive neuropathies in some patients, acute renal failure, like as we see in drugs. There are so many drugs that can cause renal failure in HIV patients, including highly active retroviral agents, highly active antiretroviral agent, that's HAART. Okay, so infections. Remember that HIV patients are prone to a lot of infections, especially opportunistic infections. Okay, so as their CD4 counts begin to drop, they become more prone to some of these infections. Then HIV infection in renal replacement therapy, we have blood transfusions, IVDA, sexual contrast, allograft. So let's come back to this HIVAN. We are now going to zoom in on HIVAN in particular because that's what this topic is about. So HIVAN, there are some common pathologies, pathogenesis by which they occur, and there's the uncommon one that we can see here, right? So the common ones, like I mentioned earlier, is focal segmented glomerulosclerosis. Remember I told you that FSGS is synonymous with HIVAN. So once you're talking about HIVAN, you must talk about FSGS. And the particular FSGS that we are referring to is the non-collapsing FSGS. Very, very important in this situation. Then messenger proliferative, MPGN, and then IgA nephropathy. Now let me tell you the difference between IgA nephropathy and FSGS. In FSGS, in HIVAN, when you see a black man with HIVAN, it is most likely the non-collapsing FSGS. When you see a white man or an Asian man with HIVAN, it is most likely an IgA nephropathy. Okay, so the uncommon other causes are hemolytic uremic syndrome, TTPs, thrombotic thrombocytopenia purpura, membranous nephropathy, amyloid. Okay, but just know this one. If there's nothing else that you noted, FSGS and HIVAN. Okay, then IgA nephropathy and HIVAN in whites. Now, this is what I just mentioned. Okay, white or Asian IgA nephropathy. These graphs are just showing the prevalence of white versus black, which one is more popular. You can see in the black nation, FSGS is quite high, while in the white nation, proliferative glomerulonephritis is quite high. That's MPGN. So HIVAN incidence has been on the rise. The incidence is supposed to match the. So let's look at the red arrow. Incidence of new HIV cases has been on the decline, with the advancements in new technologies preventing HIV, more knowledge and education about this, the pathogenesis of HIV and how it spreads, okay, and of course the use of condoms and other control measures, right? So since a certain year, it has been on the decline. Now, the same thing happened. Let's see, number of HIV deaths peaked at a certain year, and now has been on the decline. The same thing now happens with HIVAN cases, HIV-associated nephropathy. The blue one, okay, you can see it peaked initially, and then it's now dropping gradually together with the years. Okay, together with total HIV cases. So it's a good thing, right? Now, pathophysiology of HIVAN, very quickly. Genetic susceptibility. HIVAN is more likely to occur in Black, African ancestry patients than any other person. Okay, so there's a strong relationship with this APO1 gene and MyH9 gene. Okay, then it can have some of the other effects, direct viral effects. So HIV itself, the DNA and mRNA can be found in the kidney tissue, and this will affect the the nature of the kidney. And particularly, there's this NEF gene is very important in this pathogenesis, and the VPR gene is also important. GAG and POL genes are not involved. This is an potential multi-choice question, right? Then mechanisms of renal injury in HIVAN. Opportunistic infection, okay, like I mentioned earlier, once the CD4 count start dropping beyond a certain level, opportunistic infections begin to occur. And these infections by themselves can also affect the kidneys. Infection of immune cells, like we know HIV is about, destruction of immune cells, attacking of, CD4 positive cells, okay? So as these cells are dropping, so cytokines are going to be released, and these cytokines are going to recruitment of inflammatory bodies towards the kidneys, and when these inflammatory cells deposit on the kidneys, they can cause inflammation and destruction of the renal cells, tubules, glomerulus, and so on and so forth. So infection of renal cells, toxicity due to HIV accessory proteins, host response. Okay, yes. So we have, particularly in this host response, we have particular susceptibility in African patients or patients of African descent. So you can have podocyte injury. Just note some of these things: podocyte injury, adhesion, capillary collapse, matrix expansion. You can see here. Okay. So these are all possibilities of what could happen. So in collapsing, the primary renal pathology of HIVAN, is collapsing FSGS, like I mentioned earlier. So you have collapsing FSGS when you do a microscopy, renal biopsy and microscopy of the lesion. You see collapsing FSGS, you see interstitial inflammation, you see tubular atrophy. Very, very important, tubular atrophy. Microscopic tubular dilation, okay, that's why it's called the non-collapsing type. You also see casts, proteinaceous casts. So HIVAN presents typically, predominantly in patients of African ancestry. African ancestry. Very, very important point to note. Now, and usually it can present early, but typically presents when CD4 counts is less than 200. Another very important factor. Now, the most important factor in HIVAN is that it doesn't present typically like a classical CKD. You know, in classical CKD, you have tiredness, you have bilateral leg swelling, you have elevated blood pressure, and so many other features, right? But in HIVAN, okay, this patient is coming with mild or no edema. So maybe the patient is just having ankle edema, right? Then you check the blood pressure. Blood pressure is normal. This is not what you're expecting from in a patient with chronic kidney disease. So in HIVAN, they are getting normal blood pressure, no blood pressure, no hypertension, right? Normal blood pressure, okay, which can make the disease to be difficult to diagnose. But do you know where you're going to catch this disease? You make your diagnosis by looking at the protein in the urine. Once you see proteinuria, your index of suspicion should increase. So let's see the classical presentation of HIVAN. You have massive proteinuria. Remember I mentioned it earlier. Massive proteinuria, up to 2+, 3+, right? Microhematuria, azotemia, despite azotemia, where you have elevated urea, elevated creatinine, and rapid progression to end-stage renal disease. Okay, some of them can even progress to ESRD within 3 to 4 months. Some of them, okay, so it can be quite troublesome. African American descent patients is a risk factor. CD4 count is lower than 200, like we mentioned earlier. They are normotensive, very important point. Normotensive. And when you do an ultrasound scan, you will see large echogenic kidneys on ultrasound, like you can see here on this ultrasound scan. Okay, so the natural history of HIVAN, it has a malignant course, very malignant course. So end-stage renal disease within 3 to 4 months. Let's come on now than 10 years ago, okay? And heroin-associated nephropathy is a differential diagnosis. So this classical case, you know, there's this like a case summary of a patient that we saw recently. You can see he's a 39-year-old black male, classical black male, diagnosed with HIV. Sometimes this HIVAN can even be the first presentation for a patient with HIV. Okay, so it's very important to have high index of suspicion when you are seeing patients like this. Okay, ankle edema, I told you it may be mild or no edema. Okay, you check the blood pressure is normal. Serologies are negative. Creatinine is more than 221, which is elevated. Okay, then 24 hours urine protein is showing 2 grams per day, quite high. Then renal biopsy is what we are seeing here. Remember we said in the renal biopsy we are going to be seeing FSGS, classically in the black male, non-collapsing FSGS, okay, tubular dilatation, you know, a lot of things, inflammatory cells, proteinaceous casts, a lot of stuff that you're going to see. Okay, then treatment, the treatment of HIVAN, particularly, remember that there is mild edema, so diuretics is not going to be playing a significant role. You can use diuretics sometimes, they do use, if you have mild edema. For example, the patient above had ankle edema, so you can use a little diuretics, right? But the primary stuff you are going to do, one, is to commence ART. You need to commence ART as early as possible for patients with this condition. Okay, so once you commence ART, antiretroviral therapy, you are going to start seeing an improvement in the clinical condition of the patient. Because remember what I told you, that these viral cells are actually directly involved in the pathogenesis. So some of them go and infect the renal cells and start damaging the renal cells and start leading to problems in the glomerulus, podocyte, tubular cells, and all those stuff, right? So as you start commencing antiretroviral therapy and this cell and this virus starts getting suppressed, then you start seeing a significant improvement in clinical features of the patient. Then ACE inhibitors, remember that proteinuria can be massive in this patient. So ACE inhibitors, ARBs, are very, very important because why? They have anti-proteinuric effects. So once you give these ACE inhibitors, they will reduce the amount of protein that is appearing in urine, which on its own is also very important for the progression of renal damage. The more the proteinuria, the faster the renal the progression to end-stage renal disease. Okay, so in the last our last class, we actually had a discussion on CKD, right? Yeah, so this topic CKD here, and we talked about progression to end-stage renal disease, right? So serum creatinine more than 790, hemodialysis. Once you get serum creatinine more than 790 micromole per liter, go for hemodialysis. And of course, we know these are what we call renal replacement therapy. Okay, so hemodialysis, kidney transplant, they are all renal replacement therapy, RRT. So once you see patient that is having a grade 3, from grade 3, grade 4, okay, grade 3B, grade 4. Grade 3B, you start planning for renal replacement therapy. From grade 4, which is from 15 to 30, right, of EGFR, 15 to 30 EGFR, you start hemodialysis. By the time patient is getting to end-stage renal disease, which is less than 15, you should be you should have planned for your kidney transplant by then. But hopefully, if you manage properly, patient does not get to that stage. There's also a place for steroids, but this must be handled on a case-by-case basis, considering by a professional nephrologist, okay, a senior nephrologist who is quite experienced in the management of HIVAN, okay, okay, probably a subspecialist in HIVAN will be able to prescribe these steroids on a case by case basis, considering the risks benefit ratio, okay, before commencing this thing. But there have been cases where prednisolone was used for up to 2 to 11 weeks, okay, and they found out that there was actually an improvement in the patient's clinical condition. So, patients diagnosed with HIV, end-stage renal disease, renal biopsy showed FSGS, treated with antiretroviral therapy for 3 months, creatinine fell, dialysis stopped, renal biopsy showed reversal of FSGS. So that treatment with ART is the first line, okay? It's the first thing you should think about. So remember, it's classical black patients who have this FSGS. While white patients have this immune complex disease, like we see MPGN and IgA nephropathy, like we mentioned. So host factors like in FSGS, like APOL1 gene, ACE gene, H9, okay, my H9, MYH9 gene. These are very important in this thing. So renal complications of HIV medications. Now there are so many medications that are given in patients who are HIV positive, depending on the situation. So now, each of these, many of these medications have effects on the kidney. So let's look at aminoglycosides. We know aminoglycosides are nephrotoxic. So drugs like gentamicin, vancomycin, depending on the situation, some of them do come into play when you have severe, sepsis and bacterial infections in HIV positive patients. Ciprofloxacin also can cause interstitial nephritis. Pentamidine, rifampicin used in TB. So we know that HIV and TB can have a serious co-infection, right? So which means that there may be a place for rifampicin in a patient with HIV. So this can actually affect the kidney. Some of them have interstitial nephritis as as a cause. Then trimethoprim sulfamethoxazole, which is a sulfur and trimethoprim combination, they do have effects on the kidneys. Remember that this can be used to prevent PCP, which is pneumocystic Jirovecii pneumonia. Okay, so or pneumocystic carinae, whichever. But the current definition, the current terms now say we should call it pneumocystic Jirovecii, right? So this is used for treatment and prophylaxis of PCP, and it can have some exothermic effects on the kidneys, right? So antifungals like amphotericin B, as the CD4 counts begins to drop below 100, you start having some rare diseases. Fungal infection causing sepsis, fungal infection causing pneumonia. So amphotericin B IV is usually very important in this case. And sometimes it can even cause fungal infection, can even cause meningitis in HIV patients. So it's very important. Then also SP, remember we mentioned SP as well. Then, particularly of high epidemiological importance is tenofovir. Tenofovir is highly associated with proximal tubulopathy. Okay, so it is one of the direct antiretroviral agents that is associated with renal disease. So HIV itself can cause renal disease, and some drugs that are used for treating it can also cause renal disease. So that's where this tenofovir comes in. But if you do have problems with tenofovir, you can switch to another medication called abacavir, okay, as a replacement for tenofovir because it has less likelihood of causing renal involvement. Now, other HIV antiretroviral medications, acyclovir, cidofovir, indinavir, ritonavir, all these ones are protease inhibitors, okay, and they do have some effects on the kidneys. So you don't combine tenofovir and ritonavir because it will have this, especially in patients that are already diabetic, that already have renal involvement. So this drug is supposed to be widely used, tenofovir disoproxil fumarate (TDF). It's now widely recommended as a first-line HIV medication in adolescents and adults by WHO and Nigerian HIV treatment guidelines. It's a first-line medication, good and fine, but you need to consider so many factors before you commence it. You need to make sure that the patient's age, check how far this HIV condition has gone. Okay, what is the stage of the HIV at this point? Then you also need to check if the patient has any underlying renal pathology before you commence this medication. Because if the patient already has an underlying renal pathology, it is going to progress quite faster. Okay, so TDF is excreted in urine unchanged by a combination of glomerular filtration and proximal tubular secretion, and this explains why it's going to have some effects on on the kidneys. So it's been found that this has quite a significant loss of kidney function in those who use this drug versus the control. So many studies have proven this over and over and over again. These are different studies. This is a patient that the pink one is not using this type of drug, but the blue one is using this type of drug, and you can see there is an affection of the kidney, a drop in the renal function. So older age or patients that have comorbidities are more at risk. So there are some associations, MRP4, MRP2. These are genes that are involved in this, in the receptor in the kidney. Okay, and that's how tenofovir acts. So MRP4 is related with drugs like acyclovir, NSAIDs. So if you give tenofovir, for example, with NSAID, then you are increasing the likelihood that you're going to have toxicity. If you give tenofovir with like acyclovir, you are increasing the chance you're going to have toxicity. If you give tenofovir with something like ritonavir, then you are increasing tenofovir concentration and you're going to increase the nephrotoxicity of tenofovir. So these are the things to note. Okay, so when you do a renal biopsy, you will see proximal tubular injury ranging from diffuse and severe to mild and localized. So you can have acute kidney injury, AKI, CKD, decreased EGFR, hypophosphatemia, osteomalacia. These are all possibilities of things that you can find. So do consider pre-existing renal impairment before you commence tenofovir, right? The age of the patient, so older patients are more at risk. Advanced HIV disease more at risk. People that have other metabolic comorbidities like diabetes, hypertension, are more at risk. Concomitant use of nephrotoxic drugs or protease inhibitors like ritonavir. Okay, remember we mentioned acyclovir in MP4. We mentioned the ritonavir in MP2. So these are very important to note. Low body weight, very important. Patient that has hectic, that has lost a lot of weight, will be more at risk of getting tenofovir associated renal involvement. So MRP2, MRP4, polymorphisms. So how does it present? When you do a dipstick, you see proteinuria, you can see glycosuria. Of course, you expect the EGFR to be affected. So you need to check all these things before. So it means you need to do urinalysis, complete blood count. What else? Check the renal function. All these things you need to check before you consider commencing tenofovir. And if you see any, for example, the patient was stable and then you commence tenofovir, if you see any affectation of the renal function, it means you monitor the renal function at least monthly initially, then 3 monthly, then 6 monthly if there is none. Okay, so if you monitor and then you see that the patient's EGFR has dropped, you can discontinue. Once it has dropped beyond 60 mils per minute, please discontinue tenofovir, and you can replace it with abacavir. Okay, very important to adhere to this because if not, it will get worse. Remember, in summary, kidney disease is the fourth leading cause of death among patients with HIV. Okay, so we need to find out the causes of death in patients with HIV. What's the leading cause of death? What's the second leading cause of death? What's the third leading cause of death? And then renal disease is the fourth leading cause of death among patients with HIV. Then HIVAN is associated with genetic susceptibility. Very important. This statement is very, very important. So that's why Africans, people of African ancestry, are more likely to have HIVAN than any other ancestry. And when an African has HIVAN, look for non-collapsing focal segmental glomerulosclerosis (FSGS). Okay. Then when a white or Caucasian or Asian has what do you call it, a HIVAN, then person is more likely to have IgA nephropathy or MPGN. So the African ancestry is associated with this APOL1 gene, and that's also why we have African ancestry having a lot of essential hypertension. This APOL1 gene is very important. Then my H9 gene as well. So HIVAN is a form of collapsing FSGS that is potentially treatable. Okay, so tenofovir is associated with nephropathy, reversible if discontinued early. If you discontinue that tenofovir early when the patient is having tenofovir associated nephropathy, then there's a chance that this thing can be resolved. I believe there are no questions since I'm representing this topic. So thank you very much for listening today, and I hope if you do have any question, put it down in the comment section, and I'll attend to you as soon as possible. Okay, so thank you very much for attending the class today, and do take care of yourself. Bye.